Good.
The title of my presentation is, as you see, Rational Use of Medicines, an Overview and Oman Experience. So, the outline of my presentation consists of two parts. The first part regarding the overview of rational use of medicines. And the second part will be the rational use of medicine experience in Oman. So, in the overview, I will talk in brief the definition of rational use of medicines, the common problems in medicines use, what are the different factors underlying rational use of medicines, the adverse impact of irrational use of medicines, and strategies and interventions to promote rational use of medicines. Regarding the experience of Oman, I will just talk about the achievements and the constraints, and I will finish by conclusion. Rational use of medicines, or the word rational, has different meanings, such as, for example, sensible, logical, but in our culture, when we talk about rational, ترشيد, we mean by it ربط الأحزمة على البطون. It means, نقلل من كل شيء. This is not the right definition or the meaning of rational use of medicines. Okay, so what's the definition of rational use of medicines? In 1985, there was a big conference of experts held in Nairobi and organized by WHO. In this conference, they defined rational use of drugs, that rational use of medicines requires that patients receive medication appropriate to their clinical needs. So this is what Dr. Amal mentioned today. This is the first and the most important thing. When we prescribe, we should be sure that it's appropriate medicine, or it is according to the clinical need. And the other thing is the dose. So the dose should meet the individual requirements. Not for everybody we prescribe the same dosage. We have different factors influencing the dosage. So we should consider this thing. And for an adequate period, in many prescriptions you may find it's either not written or not the adequate period of time. At the same time, today we talk about pharmacoeconomic, and they focus about the cost of treatment or the cost of medicines. So it has to be at lowest cost to them, to the patients and their community. So what are the criteria for rational use of medicines? First of all, appropriate indication. Second thing, appropriate medicine based on efficacy, safety, suitability, and cost. And the third thing, appropriate dosage and administration. And the last thing is correct dispensing, including appropriate information. This is very important and always ignored or missed, that dispenser does not give the information for the patient. And it's not moved. Okay, and the last is patient compliance to treatment. So the types of medicine use problems, there are three types. The first one is related to prescribers. We call it prescribing problems. And the second one related to dispensers, which is dispensing problems. And the other one related to the patient's use problems. So in general, this information came through collected prescriptions. What do we find? What are the most common problems we found in those prescriptions? First of all, wrong medicine is used or prescribed. We talk about use either by prescriber or dispenser or the patient. So either, incorrect right, incorrect diagnosis, or even sometimes right diagnosis but wrong medicine. Maybe, I mean, the medicine is prescribed may have interaction with other medicines a patient currently used or comorbidity. Medicine is not needed. Sometimes, I mean, they prescribe or they dispense or patients use medicines which are not really needed, or sometimes more or less medicines than needed. The other thing, needed medications are not used. This is what we mean by rational. It's not always, I mean, many medicines or high doses. Sometimes even, why not to prescribe if the patient need to be treated with medicine? Why not to prescribe more than 2 medicines if it's the right, I mean, for the patient? The other thing, prescribing or using unnecessarily expensive, either as brand names or new medicines, while or the when, I mean, less expensive would be effective and safe. And the other thing is dangerous medicines. Sometimes patients are prescribed or doctors prescribe or pharmacists dispensing dangerous medicines, medicines with doubtful, unproven efficacy, or even uncertain safety, or banned medicines. Still, in some countries in our regions use banned medicines. Okay, related or problems related to dosage and administration. Either dose too long, too large, or too low, frequency is higher or lower, duration also long or brief, quantities, sometimes quantities, even quantities expensive because of the package. I mean, if a patient needs to be 5 and the strep contains 10, the dispenser gets 10, maybe, or bottles. Maybe 30 tablets, and the patient needed to be treated with only 20 tablets. So we should consider this. The other thing is administration or route of administration by incorrect way or route. Now I will just, in brief and very quick, I will show you some results regarding the medicine use indicator studies. Those studies were conducted in public primary health centers in developing countries. First, what we find, you find from this slide, there are too many medicines prescribed by patients. There is polypharmacy. I have a lot of prescriptions where some patients prescribe 10 medicines or 12 or why to prescribe all these things? So here I think if you see in Ghana, more than in average, this is in average more than 4, almost 5 medicines per patient. And this is in primary health center, not in tertiary hospital or admitted patient. The second results is high percent of medicines prescribed by brand name. We talk about pharmacy economic, we talk about cost effectiveness. So we should consider, writing or prescribing or using, generic medicines when, where they are less expensive, generic is available. Okay, not to prescribe. Here we have Ecuador also. See, about 40, just only percent. This is in a public health facility, and just only 40% of medicines were prescribed by generic names. Here also there's inappropriate prescribing of antibiotics. Sometimes antibiotics, or in many prescriptions, you found patients suffering from non-bacterial infection or even non-infection. They prescribed antibiotic, and sometimes those antibiotics were prescribed in inadequate doses. And we have different countries where you can see in the slide, and you find in one of these countries in Africa, more than 60% of prescriptions containing antibiotics. Then patient receiving injections also. There is overuse of injections where oral formulations would be more appropriate. Why to prescribe injections? If, I mean, a patient can use oral preparation. Again, see in Ghana, more than 50% or more than 55% of the patients receiving injections. And this is just global results of using injections. Here also, failure to prescribe in accordance with standard treatment guideline. We study the prescriptions. This is, of course, not our study, but we have also some studies. Also, in many health facilities, they don't, prescribe according to the standard treatment guidelines. Even though in many countries in our region, they don't use standard treatment guidelines or protocols. Okay. Again, short consultation time, which is very serious. To spend a very few time with the patient in consultation and writing the prescription. So you can see here in Malawi, less than or almost 2 minutes. Spent in consultation time. Again, short dispensing time. Dispensing time, for prescribing time or consultation time, it's measured in minutes. But consultation time, because in general, dispensers spend a few or seconds sometimes, even though. So it's here measured by seconds. See in Nigeria, less than 50 seconds. Inadequate knowledge of correct dosage also. Percentage of patients knowledge of correct dosage in primary health centers. Again, we find, patients does not know the correct dosage. This is patient care indicators. Okay, so now after we addressed the problems, we go to the factors underlying irrational use of medicines. Because of the time, I'm not going to talk about all, but these factors either related to prescribers or dispensers or patient and drug supply, drug regulation and industry. Okay, let us see for dispensers. For dispensers, what are the factors underlying irrational use of medicines? First of all, lack of education and training. That's why we have this conference, in order to correct, and one of the problems, the irrational use of or irrational dispensing. The second thing is inadequate information. I think the information sometimes it's, gained by the pharmacists are not sufficient or from unscientific or sources. Okay, heavy patient load. Sometimes, dispensers have to dispense for 50 or 60 patients in few hours. Misleading beliefs about efficacy, financial interest. Why? Some pharmacists dispense the most expensive medicines because the margin of profit is higher than when dispensing the cheap. We have the drug company influence. We have also poor communication with the patients. Go to the other slide. These are the impact or adverse impact of irrational use of medicines. In brief, irrational use of medicines cost health and money. And if you go through the slide, you will find health in form or in words, other words, reduced quality of life, increased morbidity and mortality, waste of resources in money, will lead to reduced availability and increased cost, risk of unwanted effects, psychosocial impact. So these are the general. What are, okay, we know the problems and we know the factors underlying the problems. So what should we do? What interventions we have to do regarding these problems? These are, in general, we have 4 different strategies or interventions. We have educational intervention, we have managerial intervention, we have regulatory intervention, and economic intervention. Let us focus only or mainly on the educational, as we are academic or we are from different pharmacy schools. So educational, the objective educational is to inform or persuade, okay? And whom to persuade or inform? The patient and health provider as well as consumer. So WHO mentioned 10 different strategies to promote or to improve the use of medicines. The first strategy is evidence-based standard treatment guideline. Should be available in all health facilities. Again, second one is essential medicine list. And this essential medicine list based on treatment of choice. And what we do in our countries, we started with essential medicine list. This is the wrong way. We have to start with standard treatment guidelines, and from standard treatment guidelines, we take the drugs of choice or drugs included in the standard treatment guideline. We have the third thing, pharmacy and therapeutic committees in hospitals. At least we started in hospitals or in regions. Then we have problem-based pharmacotherapy training, which is very, very important, and continuous medical education. We should rely on independent drug information. We should have supervision, audit, and feedback, and also perverse financial incentives. We have to avoid that, because if we have, to do it, but financial incentives, but in a correct way, and should be monitored or should be guided, not just only opened, otherwise it will be in the wrong way. We should have, we have medical regulations. These medical regulations should be enforced. It's very important. In our regions, we have a lot of regulations, but a little of these regulations are reinforced or enforced. All these strategies need investment, government investment for medicines and staff. I won't go through. These are programs carried out in different countries or globally or nationally and in collaboration with WHO. Fortunately, I attended some of these workshops or training courses. Okay. Now we will talk about the experience of Oman to promote the rational use of medicines. Again, this is Oman. I think all of us know where is Oman and some important background about Oman. But before rational use of medicine, Directorate of Rational Use of Medicine started, there was a study. First of all, most health professionals were expatriate in Oman until now. In 2000, the number or the percentage of GPs or medical officers, 80% were expatriates, and 72% pharmacists. Maybe Dr. have the new information. This is in 2000, 72 pharmacists and 49% assistant pharmacists, because there is institution for assistant pharmacists, but there is, at that time there was no.
It's a moving target, actually.
Yes, I will show. Okay, but still they need, I mean, expatriates, and they use expatriates in different health professionals. So, because of this high percentage of expatriates, they have variety of background and training. They come from different, all over the world, from different countries, not just only Arabic countries, from most from East Asia. Okay, faced problem with local patients due to attitude and beliefs, and this we should consider. You know, in foreign countries, sometimes you have to prescribe for the people, otherwise you will get problem with the people. So this is one of the obstacles, I mean, to promote the rational use of drugs because of this. Second thing is no health professional were trained in, at that time, no rational peoples or health professionals trained in rational use of medicines. We have studies, or one of the studies conducted before or in beginning of 2000 showed that there is irrational use of medicines. I gave just only two indicators. The first one is the average number of medicines per prescription, and the results of that study, there was 4.5 medicines per prescription, and there was 60% of prescriptions contain antibiotics. Okay, in Oman, medication are free, or medications are free for Oman citizens, and non-Omani or expatriates work in government sector. High demand of medicines, and there is irrational use as well. And there is a registration system. At that time, there was no registration system. So what are the steps in establishing the first name for this directorate was Directorate of Rational Use of Medicine, or Directorate of Drug Use. Directorate of Rational Drug Use. But now change it to DRUM, Directorate of Rational Use of Medicines. Okay? So in this time, there was a concern about, this is after 2000, there was concern about irrational use of medicines. This came through, there was a visit of WHO expert who assessed the pharmaceutical sector in Oman, and he wrote a report. In his report, he addressed, the irrational use of medicine problem, and his report was fully supported by His Excellency the Minister of Health, and accordingly the Directorate of Rational Use of Medicines was established in April 2000 by a ministerial decree, and this directorate is a separate directorate, independent, autonomous directorate. It reports directly to His Excellency the Undersecretary for Health Affairs. And DRUM, or the Directorate of Rational Use of Medicine, started with a small group of professionals. There were just only 2 pharmacists and 1 physician only, and also the administration people or administrative people. Rational use of medicine in Oman is the first of its kind in the world. There is no directorate, autonomous directorate in other countries. Probably in some countries, just only small departments under the Directorate of Pharmaceutical Affairs or Pharmacy. So this is the organogram for the pharmaceutical sector in Oman. There are 3 different pharmaceutical directorates. The first directorate is the Directorate General of Pharmacy Affairs and Drug Control, and the third one is Directorate General of Medical Supply, and the one in yellow is DRUM, or Directorate of Rational Use of Medicine. So when we talk about Directorate of Rational Use of Medicine, there are 4 sections. The most, not all are important, but the most scientific ones, or the section of pharmaceutical studies or survey and pharmaceutical studies, and section of training and public education. I was honored to establish this section and to be the head of this section for the last for 6 years. So what are the functions of Directorate of Rational Use of Medicines in order to promote the drug use of medicines? Research, publication, education, and training. So these are examples of researches conducted by the Directorate of Rational Use of Medicines. We did prescribing rationality by doctors at primary healthcare facilities. The other topic was prescribing patterns of nurse prescriber in Oman. In Oman, nurses in certain areas allowed to prescribe medicine. So we studied their, practice or pattern of prescribing, mainly in remote areas or in some areas where there's lack of doctors, mainly afternoon.
Sorry, doctor, because this is a very important point. It's a very short list. It doesn't exceed 10 number of medicine.
Okay. Yes, I agree. The information given by Dr. Mustafa, and accordingly we publish it. You can see later formulary for those medicines which are allowed to be prescribed by. Okay. So these are the examples of the researches conducted by Directorate of Rational Use of Medicines. Regarding publications, we have biannual newsletter called Pharmacologicals. We mainly focused on rational use of medicines. Okay, these are the publications Dr. Mustafa mentioned about. There are just only few medicines which are allowed to be prescribed by nurses, and we found that we should guide the nurses how to prescribe. We give the information, so we have small formulary for those medicines allowed to be prescribed by nurses. We have Oman National Formulary published by DRUM. We have also guidelines regarding chart in general for general or common diseases, and for specific diseases such as drugs such as AIDS and atypical antipsychotic drugs guidelines. We also published materials for public. So this is a small booklet published for school children. These are examples for the training and education. So we prepare the educational materials and educational and training materials and manuals. We trained doctors, we trained nurses, we trained pharmacists, we trained assistant pharmacists in the rational use of medicine. So there are either national training or regional training, or sometimes facility, health facility training. This is an example of the training conducted. By the way, we've mainly focused on training of trainers. So those who are trained by us, they train other health professionals. So this is an example in one of the health facilities where one of our trainees train the other peoples. These are examples also for education and training of patients and community. We have materials, we have manuals, very attractive and very simple. So this is patient education. Is in one of the health facilities. You can see we have in Oman, by the way, there is a school where they bring the health indicators. Okay, so these health indicators help in training public. This is also.
Ahmed, can you conclude?
Okay, so this also. Okay, so these different ways of training, even we reach people in their houses or women gathering in order to educate them in rational use of medicines. Different places. If you see here, even in bazaar, no, this is mothers or women gathering here in supermarket or hypermarket. Here also in one Suq al-Arba'a or bazaar, okay? We have to reach them, otherwise you can't teach people. So what are the main achievements? First of all, rational use of medicine nowadays is a part of the 5-year health plan. Health professionals, of course, have the opportunity to be trained in rational use of medicines. Newly graduated, those who are graduated from abroad, we train we make oriented program on rational use of medicines. There is improvement. If you see the results regarding the study conducted in 2000, the number of medicines per prescription was 4.2, and in the last study reduced to 2. It means there is a reduction in the irrational use of medicines. There are some constraints. Okay, we still, we have to fight and we have to go smoothly regarding, so that we still, still have problem of lack of human resources, because recruitment is not easy. Not everybody can be, can train or produce rational use of medicine materials. It's not that easy.
One more
okay.
slide.
Okay, this is conclusion. The last, sorry, conclusion. DRUM, Directorate Rational Use, Directorate Rational Use of Medicine, is free to plan operation on rational use of medicine, which was not exist in the old days, and they report directly to policy maker making levels, to end unit, and for feedback and follow-up, can act as rapid response. If there is any problem regarding the irrational use of medicine, we respond rapidly. But we should consider these 3 things, because people think that, so DRUM team is not a fire service, is not a police or drug policeman, and not FBI. Okay, and thank you very much.